So we're gonna start the musculoskeletal exam. Whenever you're looking at any part of the body, the back, the shoulder, knees, whatever, you're always gonna pay attention to observation first, looking to see if there's any joint deformity, inflammation, sign of trauma, any bruising, anything like that. And then you're gonna palpate to see if there's warmth or tenderness or deformity with that. As you're looking at the spine, we're first going to evaluate, does it appear to be straight? And I can look from the side and notice the cervical lordosis, a little bit of thoracic kyphosis, and then lordosis of the lumbar spine, which is all normal. I want to palpate over the spinous processes down the back, and don't feel any deformity, and she's not reporting any pain. I'm sorry, my hands are cold. And then palpate the paravertebral muscles on either side of the spine, noticing if there's any pain with that. Range of motion, you want to turn around for me? So for the cervical spine, I would like you to look down, look up, put your ear towards your shoulder on one side, ear toward the shoulder on the other, and then turn your head left and right. Okay. And then I'm going to check strength by having you lift your shoulders up and then push your face against my hand here, push your face against my hand there. Okay. If I was worried about any sort of problem with the cervical spine, I would also test reflexes, brachioradialis, biceps, triceps, and even test for upper motor neuron problems by doing the Hoffman and the Babinski or the plantar reflex. Then we want to do Sperling's test. So if the patient reported pain on this side, I'd like you to turn your head and look up in this direction. You kind of rotate your head like that. Does that hurt? Okay. If that hurt, then you would stop there and not progress anymore. But if that doesn't hurt, then you want to apply axial pressure along the same axis as the spine. Does that give you any pain? No. Okay. So that's a negative test.
Numbness in your arms or hand at all? Okay, good. I want you to do one thing for me. I want to put your ear to this shoulder for me. Now look up to your left. Okay, hold it right there for a few minutes. Is your arm going numb? Oh, it is. Oh, okay. All right, you sit back down. That's the entire exam.
For range of motion of the thoracic and the lumbar spine, could you just back up a little bit so you have room? Go ahead and lean over and tell me if you have any pain. If the patient was experiencing pain, you would document at what level of flexion she had that pain. Okay, come back up. And then lean back as far as you can go. Does that bother you? Okay. Can you lean to the right or the left? And then lean to the other side. And then rotate. Any pain with any of that? Okay. Now, if I want to evaluate the patient for scoliosis, I'm going to just run my fingers down the spine and see if anything looks out of place or if it appears to be straight. I'm going to evaluate the height of the shoulders and see if they're symmetrical. I can feel the base of the scapula and see that that's in the symmetrical place. The other thing that sometimes happens is that they get rotated like this, and I don't see that. And then at the iliac crest, I'm checking to make sure that height is normal. Have the patient lean forward as far as you can go. A couple tests for ankylosing spondylitis. One is just chest expansion. So if you were doing this exam officially, you would have the patient in a gown and be looking directly at skin. But in this case, we're doing it with a shirt and partial clothes on. But you would have the patient breathe out, kind of pinch up a little bit of skin, and then take a deep breath in. And I'm watching to see that my thumbs move apart when I do that. Okay. And then for Schober's, I want to look for the PSIS dimples. So they would be right here. I put a little mark over the spine right between those two. Then I would measure 10 centimeters above, 5 centimeters below, and then I would have the patient lean forward as far as you can go, and I'd measure between those two upper and lower lines and see how much they increase. It should increase by at least 5 centimeters. Okay. All right, and then we're going to do some tests for nerve impingement or radiculopathy. So you can sit all the way up on the table. So one of the things that is nice to do early on is the seated straight leg raise. So as you're talking to the patient, you just say, even if you're having back pain, we like to check on the knees and make sure they're okay. And so I'm looking at the knee and I straighten it out while I'm doing that. And they give you any discomfort. So a positive test would be the patient arching back like this or voicing pain in the back and down the leg. Okay, so then now we're going to do the lying straight leg raise like that. And for this exam, I'm going to just passively raise the leg in with it straight and let me know if you have any pain. If you go up to 70 degrees and they're fine, then that's a negative result. If she had pain at a certain level, then that's a positive straight leg raise or a positive SIU. If that's the case, you can verify it by flexing the knee and the pain should resolve. The other option is if they had pain at, let's say, 40 degrees with that test, I could recheck it in a flexed knee position, and they should not have pain in that position. Then there's the additional maneuver to check to see what happens with the flexed foot. So a couple ways you can do this. One is if she has pain at this level, I drop it down a little bit until the pain disappears, and then I would flex the foot, and that will probably reproduce the pain. And we have to be clear that the pain is not a pulling sensation in the hamstrings, but a radicular burning kind of pain that goes down the back of the leg, usually into the foot. And then I would repeat that test on the other side to verify that she didn't have the same symptoms. And if she did have a positive straight leg on this side, and I repeated it on this side and she had pain over on this side, that would be a positive crossed straight leg raise, which is a pretty reliable test. Lastly, take your shoe off for a second, is testing the strength of the hallucis longus. So stabilize the foot, ask the patient to flex or extend their toe up, and then you're providing resistance and you're checking to see how that strength is. And the last thing you want to do is watch your patient walk. Can you walk away from me? I'm looking for a Trendelenburg gait or any difficulty with that, and then walk back on your heels. This is a good test of strength. And then walk the other way on your toes. Okay, awesome. When examining the hips, you want to first look at how your patient is standing and see if they're symmetrical. You want to take a look at the skin and see if there's any deformity, any bruising, anything like that. Check the level of the iliac crest, and I'm going to look and palpate the PSIS and the SI joints, and then palpate the greater trochanteric bursa, and then anteriorly the ASIS joint, spine right here in the front. Okay, so then we're going to check strength, and I want you to lift up, and then lift up, and then push down against my hand, and push down against my hand. Strength testing. And then could you lie back? I'm gonna check the range of motion of your hips. I want to make sure that the patient is draped so they feel comfortable. And then with this, I'm gonna flex up, and then I'm gonna internally rotate where the knee goes, the hip goes, externally rotate, and do the same on the other side. Up, internally rotate, externally rotate, and down. The Galeazzi test is mostly for pediatrics. You ask the patient to put their feet as close as they can to the buttocks, and then you look to see if the knees are at the same height. Evaluate the any leg length discrepancy. Ask the patient to get in this position, arch your back a little bit, and then go ahead and put your legs out straight. And then you can look at the medial malleolus and compare the where your thumbs fall when palpating that area. Other specialized tests, one is Faber. So you're going to put your leg like in a, make you into a 4, and then I'm going to press in this position, and we would do that on the other side as well, and notice the patient having pain with that maneuver. Okay, and then you want to check IT band, so go ahead and lay it on your side. This is Ober's, and so this leg is bent just a little bit. We're going to raise this leg up, bring it back, and see if it can drop down. A positive test would be it just stays in this position. Let's have you come on this side, and one leg is down off the table, and this is, you're pushing against each other. You're pushing down and pulling up here, and the patient may have pain in the SI joint with that.
This is over. Okay, now just kind of roll over. Good. Hang that cheek off. Hang that cheek off. There you go. And if they don't have pain, you can further stress it. This one forward.
Sit up and put your leg over and lean forward. And that would elicit pain in the buttocks or down the back of the leg. And yeah, lift up, and you're looking to see if the hip drops down on that side.
Shoulder, check for any deformities, any musculature, any bulkiness, anything like that. So everything's symmetric, okay? Then we are going to palpate. So AC joint. I follow along the clavicle till I get to the acromion. Here's the AC joint, and you're going to do this bilaterally, so you can do it at the same time if you want, okay? And then about 2 inches below, you're going to find the coracoid process. If you push in, it's probably a little tender. Is that tender? A little bit. Okay. You'll feel it. It's a little, like, prominence there. The next thing is the greater tubercle of the humerus. Okay. And then we have, can you all see? Mm-hmm. And then we have the long head of the biceps. So, got the coracoid process. I go a little bit below, and sometimes you'll just feel it roll underneath your finger. And if the person flexes, you'll feel it tighten, okay? So you'll do that on both sides. Axillary nerve. So, would you close your eyes for me? Can you feel this? Mm-hmm. Okay, intact. So next is our passive range of motion. So you're going to do this bilaterally. You're going to go back, back, out, across, external, internal. Okay? And then you're going to do it on the other side. Up, back, out, or up, across, external, internal. So that's passive, and then you're going to have your patient, you just do what I do. Up, back, up, across, external, internal. Okay? Next, strength. So up like this, push up against my hands, push down. So that's your strength of your AB and abduction, okay? And then that brings us to our sits, correct? So we have supraspinatus, Impingement test. Arms at a 45-degree angle, thumbs down, and then push up against me. Okay? So that's your test for your supraspinatus. Your infraspinatus and teres minor. You're going to put your arms in like this. Push against. Push against. Internal, external rotation. Okay? Subscapularis. You can have the patient with their arm up back, and then they're going to push off against your hand. So push. Okay? That's your lift-off test.
Yes. It's the chicken wing.
The next is your biceps, correct? It's going to be either Speeds or Jurgensen's. So you're going to palpate in the bicipital groove. Patient's going to be in supination, and then push up against resistance. That'll elicit pain, okay? Jurgensen's, the patient is trying to do this kind of motion. So I always say it's like the patient's trying to pull the string on a lawnmower. So you can do it 2 different ways. Craig's way is much easier. So you're going to arm wrestle the patient. So you're going to kind of stabilize the elbow, and then we're going to arm wrestle, but you're going to let me win, okay? So like this, and then that's probably going to cause some pain up in the shoulder, okay? But you only have to pick one, Speeds or Jurgensen's. The next is cross arm test, correct? Oh, no. Hawkins.
Yeah.
So impingement, correct?
Mhm.
So 90 degrees, and you're going to push the arm down. Does that hurt? Okay. And again, you're going to check bilaterally, okay? Or nears. Can you raise your arm up to your ear? Near to the ear. If they can't do that, it's positive. The next is the cross arm test. So what are we testing for?
AC joint.
So can you do this? Can you do this? Okay. Next is thoracic outlet syndrome. So we have three tests. So we have the ruse test. You're gonna put your arms up like this. Have the patient wiggle their fingers. You would do this for about a minute, checking any kind of color change in the hands, or if the patient expresses any numbness or tingling, that would be a positive for thoracic outlet. The next test is Allen's test. So you're going to check the patient's pulse, and then you're going to abduct the arm, and the patient's going to look away, that way. If the pulse diminishes or goes away, it's a positive for thoracic outlet. If you don't mind standing up, this is a clavicular test, face that direction. Turn your arms this other way. You're going to get the pulse again, and then you're just going to extend the arms back, lean forward just a little bit. And if the pulse diminishes or goes away, positive thoracic outlet. All right, so we have apprehension. I stabilize underneath here, but you're going to push down. That will elicit pain, okay? And then if you push over the joint and it relieves the pain, that's positive for the relocation. Okay? And then obviously then you're going to also screen the C-spine with the shoulder complaint. Any questions? Okay.
Just shrug. I'll kind of get to the back so you shrug your shoulders up. Hold them right there. Good. Come out to the front here and hold them right thumbs up. Hold them right there. Good. Now bring them over here to the side like this. Right there. Hold it right there. Good. Bring it down here for me. Hold it right there. Good. Now come out here about here. Now turn your hand like a pointed can. Now hold it right there. Excellent. Excellent. Perfect. All right. Just relax. Does that bother you there at all, Ronnie? Okay, how about here? How about right here? Does that bother you there at all? Okay, good. Why don't you lie down here with your head at this end of the table and put your feet at that end for me, okay? Now just relax now. Now come over here toward me a little bit, okay? Does that bother you at all? Oh, it does bother you? Does that make it better? Okay, good, good. All right, stand back up.
Okay, so now we're going to do the elbows, hands, and wrists. We're going to start with your hands and your fingers. First, you're just going to look. You're just going to palpate your metacarpals, your PIPs, and your DIPs, and anything with any of that. Okay. Then you're going to find, it's called the anatomical snuff box. So what you'll do is have them flex their thumb up, and they'll have this nice little groove right there. Okay. So we just found the snuff box. And then we're gonna palpate your extensor pollicis longus and brevis, correct?
Brevis.
Brevis.
Longus.
Brevis longus. Okay, all right. Gonna have you do some active range of motion, so have you flex your wrists and extend, radial deviation, ulnar deviation. Then we're gonna do strength, grip, squeeze, and then spread your fingers apart. Don't let me push them in. Push them together, good. And then I'm gonna have you try to lift up against me. And then push me down.
With me.
Yep, just your wrist. Flip to the other side. Okay, good. Then we're going to do Tinel sign. So you'll just tap and you would have electricity feeling going through your fingers if it was a positive. Then Phalanx. You'd hold this for a while and same idea for carpal tunnel. Then you do Finkelstein's test. So you're going to take your thumbs, put them in there, tilt them down, and that would cause pain through here. And then we're going to check your ulnar collateral ligament. So you'll stabilize, and it shouldn't move very far off that way. Now for the elbows, you're just going to look. And then you're going to check their carrying angle. So just turn that way for me. Perfect. Okay, you can go ahead and sit down. And then you're going to palpate. So you want to palpate the olecranon or in the bursa, both sides. Then you're going to do passive range of motion. So you got flexion, extension, flexion and extension. Can you do the same thing for me on your own? Good. I'm going to bend your elbow. And then can you do that on your own? Good. Up. And push me back. Good.
Pull.
And pull. Good. Then we're going to do the Mills test for lateral epicondylitis. So, you're going to hold at the elbow. You're going to palpate your epicondyles. Pull that up. Flex the wrist. And then you're going to extend down. And that would cause pain. So, last but not least, nursemaid's elbow. So, usually it'll be a child that'll come in and they'll be holding their arm just like that because that's the way it's comfortable. So, the way you do it is you take your opposite hand, shake their hand, hold their elbow, and you're going to pull them up and up.
Feel that pop?
You're going to do the hyperpronation, so you're going to turn in and pull, and it should be able to reduce that way.
Quadriceps, of course, which you can milk down for the patellar ballotment if you want to, but that's not on your list. Superior and inferior pulls. Wow, have you got motility? Look at that boy, bad boy rock. Look at that. Wowzer. Huh, okay. Patellar tendon, tibial tuberosity, roll medially into the anserine bursa, and then obviously popliteal fossa is right back there.
Joint line.
Joint line between the bony plateaus, upper and lower, there's kind of a gap. Medial, lateral. Medial collateral ligament, lateral collateral ligament.
Perfect. So, ACL, anterior door, posterior door, Lachman's.
Not as good with that one. So bring it down to about 30 degrees. Relax this if you can.
Mariana's good at this one.
Good.
That's right. You have a background in this.
Yeah, this is her.
Oh my God.
Whoa.
Of course, Lachman's examination is like this. you're going to just take the knee, you're going to flex the leg to about 30 degrees, and you're going to give a little bit of a anterior force on the tibia. You feel that nice? I want you to feel like that, like a piece of cloth catching like that. Now, if you can't get around the knee, this is one way to do it. Put your knee up on the table like this. Take this arm and just pull up like that. See that? And you can just take that and just do it like that. That way, if you don't have the big enough hands to get around the leg, you can do that little variant like that. Okay? That's called a little person's allotment exam.
Right, my not putting it on the checklist. Could you do the
Varus and
okay,
valgus.
varus and valgus,
This is-
both at
Sorry.
0 degrees and 30 degrees.
Oh, that's right. You're supposed to do it at 30 degrees too. I have time with that. I need a third hand when we do that. So we'll watch her do it. Well done.
Okay.
Up into flexion, and then I was taught
Get me to hold it.
outward and hand on the joint line, pull it out, and then move it back in, move the foot all the way out, and then
It's different than that. All I do is I will rotate the foot out, go up and down there,
Rotate the
it
foot in.
go up and down here, and then same thing, rotate it in, go up and down that way, rotate it out,
So,
and up and down that way.
so basically, you're putting him through foot out and knee out, in and out, and then
Right.
knee in and out.
yes.
Okay, so first I always do just a little bit of range of motion, see if I feel grinding. And then what we're going to do is we're going to turn, and we're going to stress. We're going to stress those menisci. Okay. Menisci. Okay. We're going to stress. Yeah. So some will add a little rotation to the knee, but as long as you're turning, I start there. Because that's gonna, if they have pain there, they're not gonna tolerate the rotation in addition to it.
rotate out and in.
You're trying to get all four corners pretty much, anterior and posterior, more medial and more lateral. You go in and out a few times up, and then you do the 20-degree. Yeah.
Palpate bilaterally, feet, toes, metatarsal joints, and ankles. And palpate the anterior aspect of the ankle joint, the Achilles tendon, the medial and the lateral malleolus. Palpate for plantar fasciitis. And the metatarsal heads, including metatarsal squeeze. Okay, and then the calcaneus. All right, have the patient perform active range of motion, extension,
And then can you,
invert,
and then out.
evert.
Okay.
Okay, and then toes, dorsiflexion.
Do strength.
Plantar flexion. Okay, and then strength testing.
Push,
Push down and
Push.
pull up.
push, push.
All
And
right.
toes, push,
Toes.
push.
Do special tests for the ankle, high squeeze, and mid squeeze. Palpate the head of the fibula, anterior dorsine, ankle. Wait, okay.
How do you do Thompson, sitting or lying?
Either. So what you're doing is you're testing integrity of the Achilles tendon. So make sure that they're a little bit plantar flexed, not all the way, because if they're laying like this, you're not going to be able to tell. Right? If they're all the way down, you're stretching it too much and it may be painful, so they're resistant.
Again, do both sides, because you may have somebody with an intact.
Tuning fork test for possible fracture. So if you suspected there was a fracture, let's say here, one test could be,
Then listen.
and then listen there and compare that to the other leg. Okay. Another test could be to put it directly over the area you think there's a fracture. It should be increased pain.
On the bone.
Okay, good. And then Ottawa rules for x-rays of the foot and ankle. So you would verbalize that there would be pain over the malleolar pain, inability to bear weight, and then tenderness over the posterior edge or tip of the medial malleolus, and or tenderness over the posterior edge or tip of the lateral malleolus. So up there. Okay. For the foot, there would be midfoot pain, inability to bear weight, and tenderness at the base of the fifth metatarsal, and navicular bone pain.